Welcome back to part 7 of our Breast Surgery Coding Masterclass Explainer. Let's dive right into the source material, shall we? Today, we are unpacking the documentation around subareolar and duct procedures. Specifically, we're looking at the coding rules for nipple exploration and fistula excisions, and figuring out exactly how they apply to your daily audits.
If you recall, back in part 6, we were all about percutaneous lesion ablation. Well, today we're shifting gears. The documentation is pointing us toward open surgeries now, zooming way in on the complex anatomy of the nipple areola complex and the lactiferous duct system. The coding logic actually changes quite a bit in this area, so let's unpack exactly what the guidelines dictate.
Here's the audit arc we're following today. We'll start with anatomy and indications, move into the code hierarchy, tackle modifiers and bundling, run through a real-world op report audit, and finally, do our wrap-up.
All right, let's kick things off with Section 1, the anatomical anchor and surgical indications.
When we think about the central portion of the breast, our minds usually go straight to the lobes and ducts, out in the subcutaneous fat, right? But for the codes we're tackling today, our focus is literally right beneath the skin at the central portion, specifically the areola and the nipple. Those little pathways right there, those are the lactiferous ducts.
So, what actually drives a surgeon to operate in this specific area? Well, as always, the pathophysiology dictates the procedure. The source material points to things like neoplasms, intraductal papillomas that cause pathological nipple discharge, and chronic issues like ductal ectasia, recurrent subareolar abscesses, or chronic fistulas, think Zuska's disease. Really grasping this clinical background is absolutely crucial because it sets up the why before we even look at the how in the operative report.
Moving right along to Section 2, CPT Code Selection Hierarchy.
Okay, the absolutely crucial distinction we need to make here is between exploration and definitive excision. CPT 19101 is the code used when the surgeon is just exploring a suspect duct. And similarly, you might see CPT 191110 pop up if they're exploring a nipple fistula through a sinus. But contrast that with CPT 1911. That code is for the definitive excision of a lactiferous duct fistula. It's the whole shebang. It addresses the disease state entirely, rather than just taking a look around.
In fact, the source material explicitly defines a lactiferous duct fistula as an abnormal tract or pathway between the skin and the lactiferous duct. So for you to safely assign CPT 19112, the documentation absolutely has to show the complete surgical excision of that diseased tract, plus the skin opening and the surrounding inflammatory mass. If the surgeon just goes in to explore and, say, unroof it, no way. You cannot use 19112 for that.
Now what about CPT 19120? How does a duct excision differ from that one? Well, 19120 is for an open excision of a lesion. And yes, that includes a duct lesion. But the key detail, the thing you really need to watch for, is that it's done without a preoperative radiological marker. If the surgeon goes in for a known lesion and there's no wire placed beforehand by radiology, the guidelines point us straight to 19120.
That brings us to Section 3, the rules of the game, modifiers, and bundling.
First up on the rule board, laterality. Since the breast is a paired organ, these codes strictly require you to indicate laterality. You've got to append an LT for the left breast or an RT for the right breast. Furthermore, our source notes explicitly remind us that for procedures like that open excision code, 19120, you absolutely must append modifier 50 if the procedure is performed bilaterally. Seriously, never leave your payer guessing which side of the body was operated on. It's a surefire way to get a denial.
Now, watch out for this major bundling pitfall with CPT 19020, which is the exploration or drainage of a deep abscess. If a drainage incision is made in the exact same quadrant as a definitive excision, like removing a fistula tract, it is bundled right into that main procedure. You can't build them separately. Also, keep in mind that simple and intermediate layered closures in the areola tissue, those are automatically bundled into these primary codes as well. It's just part of the package.
Let's put this into practice with Section 4, Real-World Operative Report Audit.
Okay, let's look at a scenario straight from the text. We have a 38-year-old patient with a draining periareolar sinus tract on the left breast. The surgeon dictates the following. A lacrimal probe was gently inserted into the fistulous opening at the 6 o'clock margin. A circumareolar incision was made. The entire fibrotic fistulous tract, along with the involved skin opening and lactiferous duct, was completely excised down to healthy tissue. Hemostasis obtained, layered closure performed.
So, let's track the audit logic here. Step 1. Was an abnormal tract identified? Yes, it was probed right at the 6 o'clock margin. Step 2. Does the report verify complete excision? It sure does. The tract, the skin opening, and the duct were completely excised to healthy tissue. Step 3. The remaining duct was fully addressed. Because every single one of these criteria hits the mark, we completely skip those basic exploration codes, and we confidently assign CPT 19112. And of course, we append that -LT modifier for the left breast. Boom, clean claim. And finally, we arrive at Section 5, the Coder's Toolkit, and episode wrap-up.
To make this super easy to remember, here's your subareolar audit checklist to take back to your desk. First, always verify the specific anatomy. Are we actually in the duct or a different lobe entirely? Second, you've got to differentiate between a simple exploration, which is 19101, and a complete fistula excision, which is 19112. Just look for the removal of that skin tract. Third, check for preoperative markers. If there aren't any and a lesion is excised, you're looking right at 19120. And finally, please never forget to apply your appropriate laterality modifiers like LT, RT, or 50.
I really hope this explainer cleared up the subareolar space for you. But hey, we aren't done with open excisions just yet. Coming up next time in Part 8, we're going to dive deep into open lesion excisions. We'll be stacking 19120 up against 1925 and the add-on code 1926. We are going to focus heavily on the critical nuances of those preoperative radiological markers. Trust me, you won't want to miss it.
Remember, coding isn't just about memorizing numbers. It's about translating the surgeon's story into the language of compliance. But what happens when that story relies on tiny, invisible radiological markers placed hours before the surgery even begins? Well, we'll find out next time. Thank you for watching, keep coding with confidence, and make sure to subscribe to Decode Healthcare with Harshal. See you in Part 8.